Good evening, everyone. Welcome to NephCure's second annual IgAN Awareness Town Hall. We are so excited to have you. We're also very excited. This is our second one. I've not been able to say second a lot, so I was really excited that we can say this is our second annual IgAN Awareness Town Hall. If you were at our first one, basically the goal is to not only spread awareness, but also discuss treatment options that may have come on the horizon or may be coming on the horizon, as well as amazing new alliance that we have that's really, really pushing the narrative of the importance of IgAN ahead and ensuring that patients' voices are being heard, as well as what NephCure does best is spread information and take questions from our patients and all of our stakeholders to ensure that everyone's up to speed on all the knowledge around IgAN. It is very significant that this particular patient group gets their, I would say, time in the sun in regards to not only acknowledgement, but also awareness around the diagnosis due to it being so unique and so uniquely challenging. So at NephCure, we are committed to doing that now annually, and we're so excited to have you all here. Before I start, I want to first thank a few people who are on the call. First and foremost, Becca and Bria Garcia. They are very ingrained in our NephCure family. I feel like Becca's like my sister now. It's ridiculous. I feel like I talk to you, Becca, all the time. And then Bria, who is growing up before my eyes, is her daughter and also has IgAN. Hi, Becca and Bria from New Mexico. And then we have, go
Hi
ahead.
guys, nice to meet with you.
Then we have Dr. Daga, who is a new friend at NephCure, who I hopefully can bug a lot more often about helping with different things like this. I'm referred and connected through the amazing Dr. Sampson. Please tell Dr. Sampson we say hello, Dr. Daga, because he's such a good friend of ours. Dr. Daga is a pediatric nephrologist, and she is incredible. Hi, Dr. Daga. And then we have Susan Brizendine. I feel like is my personal friend, who is also new to NephCure family, but is making waves so big and so profound. We are so lucky to have Susan. Susan's our VP of Partnerships and Collaborations, and she is also going to speak about our new IgAN Alliance, which she has worked on and is working on building out. Hi, Susan.
Hey, Montrez. Hey, everybody. It's great to be here. Thanks for having me.
We're happy to have you. So I want to start out by thanking our amazing sponsors who make these town halls possible. Otsuka, Novartis, our friends at Travere, Pilates, Vertex, and Alexion. Thank you so much for everything you all do. We are so happy to have you as partners at NephCure. We could not do our programming without you. And we're so lucky that you make our town halls like these possible. So thank you all so much for your endless work and your tireless commitment to our RKD community. Thank you so much for everything. So first, Dr. Daga, you can of course start by introducing yourself, and then I'm handing you the controls so you can present.
Hi, everyone. It's really an honor and a pleasure for me to be here. I am a pediatric nephrologist or kidney specialist at Boston Children's Hospital. This is my first time doing something like this with NephCure, so I hope you don't feel very disappointed, and I'm happy to get any feedback. Um, I've been tasked to talk a little bit about IgA nephropathy, just how it's diagnosed and what are the recent treatment options. And if you guys have questions, please ask me at the end, or if there's something that seems too esoteric or boring, you can always just flag and say, move on to the next slide, please. Um, but it really is an honor to sort of see to be here. I'm going to share my slides. I hope we don't encounter technical issues.
We can see them.
All right, perfect. So in addition to taking care of kids with kidney disease, I also actually I am charged with the role of treating most of the GN patients, so glomerulonephritis, and I'm in the process of making a glomerular center. So I see a lot of IgA nephropathy patients and some that come from different parts that are not just in Boston. I wanted to just go over a little bit about, what IgA nephropathy is, how do we diagnose this, and kind of a brief overview of the recent treatment options. Um, for some of you who don't know this, IgA nephropathy is actually the most common glomerulonephritis, or the inflammation in the kidney, in the areas of the world that are considered the developed areas or resource abundant areas. There is other forms of glomerulonephritis like post-infectious GN that's more common in resource limited settings. But IgA is actually one of the commonest GN we see here, and is also very common in the Asian population. Not to say that it does not affect Caucasian patients, Black, but it definitely is more predominant in the Asian population. It is There's different forms of IgA, but the primary IgA nephropathy that we want to talk about is the primary disease, used to be referred to as Berger's disease. And we're not going to delve into the secondary forms of IgA nephropathy that actually occur in presence of other diseases like skin conditions like psoriasis, or bowel disease like inflammatory bowel disease, or sort of HSP, which is this vasculitis that occurs often in young kids, but also in adults. The word IgA nephropathy, IgA is basically is an antibody that we all make, and nephropathy is essentially any kidney disease. And the real classic way of diagnosing this is by obtaining a kidney biopsy and confirming the deposition of IgA antibodies in the kidney filter called the glomerulus. And typically we should not have deposition of IgA or any antibodies in our kidney filter. So that's kind of the way we confirm that a patient has IgA nephropathy. They may present, and I'll talk to you about how they present, but that's how we confirm the diagnosis. In this picture here, you sort of see these three pictures. Basically, this is one kidney filter glomerulus in what we say is light microscopy. And you see these like lots of blue cells, which is not considered normal. And there's actually this mesangial expansion. This is classic of IgA nephropathy. Then there's another test in the biopsy called IF that shows IgA deposition, and electron microscopy test, which is all these three parts are tested when you do a kidney biopsy. You see these kind of humps or deposits, which are basically representative of IgA. So how do patients present? Sometimes, and actually recently, which is actually quite, I would want to share sad stories, but last week I've been on call. We had a lovely 18-year-old who was actually starting college in September, and hopefully she still does, come in with complete kidney failure, just creatinine of 13, with symptoms of 2 weeks of just chest pain and shortness of breath. And initially in the ER, they thought, oh, let's give her some ibuprofen, maybe it's some kind of like muscle pain, but she wasn't really looking good. So they did a creatinine, and it was 13, which is really elevated and suggestive of kidney failure. And it came as a shock because she was making urine. She had no symptoms. This poor girl had leukemia at the age of 5 and recovered really well and doing beautifully well. Like, she was getting into pre-med, got full scholarship, wanted to be a pediatric oncologist, and like really smart girl. And turns out she had IgA nephropathy, and she's a Vietnamese, a race, who's Asian. But it to me, it seems like, and she'd gone to a lot of doctors before with normal blood pressures, but no one had checked her urine in the last 5 years. And so maybe she had kind of a little bit of blood, a little bit of protein in her urine that just didn't get picked up because she didn't have symptoms from it. And you don't really get symptoms from a little bit of blood and a little bit of protein. It's only when it's visible blood or it's a lot of protein that you get symptoms. So here she is kind of with kidney failure because of IgA nephropathy that just didn't get picked up. So it was just I was just thinking about kind of talking today, and, one would wish that there was some way a urine was done. In the US, there's no formal kind of screen. The American Academy of Pediatrics does not recommend screening UAs, but I wonder whether, like in certain Asian population, given that it's so common, whether that's something one could consider, doing. Because actually in South Korea, Japan, and Taiwan, every school kid gets a screening UA. But anyways, I'm going to go on this tangent. But the symptoms that this patient present, the symptoms that typically IgA nephropathy patients present with is variable. So they can be asymptomatic, or they can come with blood in the urine, the commonest thing that we see. And often it's like visible blood. Hey, I'm peeing red. And often that happens in the setting of a concurrent illness, meaning you just had a sore throat, cough, or some kind of diarrheal illness, and then suddenly you're like, oh, my urine looks red. You get seen by your doctor, the doctor refers you to a nephrologist, and that's kind of the commonest thing. And then you do a kidney biopsy, you do a battery of tests, and that's how you confirm the diagnosis. Protein in the urine can be variable. Like when you look at your urine, sometimes it looks foamy or frothy, and sometimes it doesn't. And you'll note that there can be variable grades of protein. So here, what I show is simple dipstick, which shows that this is, negative or normal protein, but the more blue it gets, that's the kind of high protein or high grades of protein. Also important that we should consider what time that urine sample was collected, because sometimes if it's just middle of the day, we can all have a little bit of protein. So that's kind of the investigation that we do. Some patients can present with, a little bit of swelling. Their labs can suggest that their kidney function is not normal. They can have high blood pressure and things like that. The IgA nephropathy was first described way back in 1968. This was one of the first papers in literature that talked about it. And way back at that time, and even up until a decade ago, it was considered a relatively benign condition in children with evidence of some blood in the urine or hematuria that was either microscopic, meaning you couldn't see it by your naked eye, or visible blood in the urine with these mesangial IgA deposits on the kidney biopsy. However, in the last decade or so, there's been lots of interesting registry data, especially from the study in UK, but others subsequently confirming that the outcomes are not always benign and that outcomes are quite correlated with the amount of protein you have in your urine. So as you can see here in the graph that if you have less than 0.3 gram of protein in a day, average for long periods of time, then you likely have a less percentage of chance of developing kidney failure versus the higher grades of protein you have, there is a high likelihood that there'll be decline in your kidney function. This study has been really looked at quite a lot. It's come from the UK National Registry of Rare Kidney Diseases. So again, the population here is just from UK, so may not apply to every race or patient population, but there's been similar studies now coming from different parts of the world, Sweden, India, Canada, and other things, where they actually show that long-term follow-up for patients with IgA nephropathy is not as good as what we thought it was, meaning that at least 40% of patients or adult patients do develop a significant decline in their kidney function over time. The important part in this paper was it's mostly adults. So it was 2,300 adults, and there were 140 kids. And patients who were selected in this cohort had some proteinuria and a little bit of low GFR. And as you can see here, even when you had very low grades of protein, like less than 0.44, that's when the chance of kidney failure was a little better. But as the proteinuria increases, even if it's like 0.44 to 0.88, the estimated kidney survival rate wasn't looking as good. And it certainly gets worse as the proteinuria increases. So this actually really, makes you think about when you do diagnose a patient of IgA nephropathy. Unfortunately, sometimes they're diagnosed a bit later, and one would hope they could be diagnosed a bit earlier. But even if they're diagnosed late, what could we do to kind of reduce their risk of developing kidney failure in their lifetime? And for me personally, since a lot of times we see really young kids, you really have their whole life ahead of them and you really want to do everything you can. But at the same time, obviously, we want to ensure that they have good quality of life and not get a lot of toxic side effects from the therapies we offer. So it's always like a fine balance. But it's important to think of, you know, like what would they do 20 years down the road? And as a pediatrician, often when they're like 21, 22, unfortunately, I do have to transition their care to an adult provider. And so I don't get to see that, but it's important to kind of keep the long-term outcomes in mind and guide your practice based on that. So what are the things that make IgA nephropathy worse? If you have more protein, high blood pressure, poor kidney function, if you present later in life, those are usually considered risk factors for progression of the disease. Why does this really happen? There's been a lot of recent data and literature and lab work around this. And so I think that has really informed how we can treat this disease. Having said that, we still have some, things that have not been answered perfectly. Briefly going over the 4-hit hypothesis, meaning that in your gut, in your small intestine, there is this mucosal lining where we all produce IgA. So whenever we get a little bug or an infection through our gut or even a respiratory tract, often there's production of IgA, which is an antibody. What happens is some of these antibodies have less sugar attached to them or less galactose attached to them. Many of the times that just stays within the intestine, it does not enter our blood system. But in some patients who have certain genetic factors that we're learning about, or certain other inflammatory conditions, or just some alteration of their gut microbiome, that results in release of these galactose deficient or sugar deficient IgA molecules into bloodstream or into circulation, which is not normal. Once that happens, that results in a cascade of the body going like, hey, I don't recognize this poorly sugared IgA. I'm going to attack it and remove it. So this your own kind of body attacks it and makes these IgG antibodies. So it's like an autoimmune phenomenon that's happening. And once these circulating immune complexes are made, they then deposit on every kind of filter of the kidney and cause kind of this whole inflammation, blood in the urine, protein in the urine, and more injury. So it's the release of these circulating sugar-free or sugar-less IgA antibodies in the circulation that causes the whole thing, the whole downstream effect. Now, why they get released and why some get more of this and less of this is still kind of an area of research. These are risk factors. So, in terms of like, how do I know whether this patient is going to have worse disease is based on the clinical, like how do they look, how late they presented, what is their protein in the urine. Then it's morphological, which is the biopsy data, which there's an Oxford MESC score that kind of helps us guide whether they have lots of inflammation or less inflammation. And then there's a whole prediction tool, which now is something we can use that we can put in all the important aspects of the patient's, recent care to determine what that tool spits out in terms of how high they are to progress in terms of disease. And so one score you can actually calculate at the time of the biopsy, and there's one risk assessment you can do a year to 2 years after the biopsy. So this has been a helpful tool to kind of really see where does your patient fit from what this may look like down the road, and that may guide treatment. The biggest shift in treatment of IgA nephropathy has happened in the last few years because of the better understanding of what's going on and where the secretion of these antibodies are. And so KDIGO is basically kidney disease improving outcome, which really had these are not finalized guidelines, but are going to be finalized very soon. But in 2024, these guidelines sort of set the stage for what the treatment of IgA nephropathy should look like, which is very different from their guidelines in 2021, which actually had mostly supportive care as the emphasis, meaning that if patients with IgA nephropathy came with proteinuria that was less than 1, then just kind of wait and watch and see how they're doing. But if it's more than 1, that's when you do a kidney biopsy, that's when you do other things. However, that has shifted significantly to now the proteinuria range being less than 0.5 being normal or being the target. So if anytime you have more than 0.5 gram of protein in the urine, you're at considered progressive loss of, or worsening of kidney disease. And you're going to do two things for these patients. You're going to try to get their blood pressure in better control. You're going to reduce their cardiovascular risk, and you're going to try to reduce the glomerular injury by using things like ACE inhibition, sparsentan, which is recently approved for IgA nephropathy, and think of medicines like SGLT2 inhibitors. At the same time, you also want to nip it in the bud. I want to stop production of these antibodies that are coming from my intestine. What can I do to do that? And recently, NephCure, which is the budesonide, which is now approved for adults, has kind of been a game changer in terms of a medicine that's approved, that's actually shown to improve outcomes for these patients in terms of less proteinuria, but also kind of attack those cells that are making IgA at the level of the intestine. And of course, the steroids have been around even before I was born, but that always helps because it reduces the glomerular inflammation. That's always sort of there. And I think it's important because in many resource-limited countries where you may not have access to a medicine like NephCure, that is something you can at least start with and provide to your patients, balancing the unfortunate side effects of these meds. Other things that have been not studied in a clinical trial way, but have shown some improvement is MMF, hydroxychloroquine, and tonsillectomies. Similar to what I had laid out in the last slide also, what is interesting is you're really trying to attack the inflammation directly by some form of steroids. NephCure is basically an oral kind of medicine, budesonide, that actually just targets the intestine directly and tells those mucosal cells to stop making this abnormal IgA. Some of it can get absorbed in the systemic circulation, so you can still see some steroid side effects. And it's supposed to be used for 9 months, but the problem is if you stop using it, what if this kind of comes back? But for now, this is an option. And then systemic corticosteroids is another option. The other medication that was approved recently was iptacopan, which is a factor B inhibitor in the complement pathway. The complement pathway is also now known to be critical in this IgA nephropathy. It's part of the immune system that gets upregulated. Iptacopan is now FDA approved for patients 18 and above in an accelerated way with the 9-month data that shows there's improvement in disease patients. So again, that's another option for some of the patients who maybe develop steroid side effects, and it could be a thing to consider. In this exact thing, there is many new drugs that are being currently studied in phase 2, phase 3 trials that some may actually get approved by end of the year or even come in by early next year. These are the BAF and APRIL. I don't want to go into too much detail there, but they're actually acting on the sort of signaling of these production of these autoantibodies. And then here, the list is just continuing to increase over the last decade. As you can see, it used to only be RAS inhibition. Now there's SGL2, sparsentan, atrasentan, which is again another endothelin receptor blockade, which was recently approved again. And there's more to come here. So definitely lots of more options now for patients, and less maybe for the pediatric world, which I'm not happy about, but because the pediatric trials happen never or happen once in a while or get closed. So we're kind of like trying to figure out and get like either, some approval or compassionate use. And I hope this can really shift in the next few years. But these are safe medications so far as what we've learned from data in the adult trials and our options for our patients. Just bringing your attention to the BAF and APRIL inhibitors that seem to be really showing some initial promising data in the recent trials that may be other options to use. And at the same time, to think about, I will say protein in the urine is an important marker, but it doesn't tell you a lot about everything with the patient, right? So if there was another way that I could measure some other biomarkers in the urine or kind of look at the biopsy and see how the patient's really responding, that would really be also useful. And I'm hopeful in the next 5 to 10 years, we actually have a perfect profile that we can do for each patient and kind of do more precise medicine as opposed to giving everyone the same thing.
Dr. Day, can I interrupt you 1 minute?
Yeah.
One thing I think that our patient community would be interested in is I know there's no ideal patient for some of these new treatment options. Like if you can go back to the treatment option slide.
Yeah.
I guess, but the question would be, if for say sparsentan and some of the other drugs that have been out for a little bit and the ones that are to come, is there any sense of overview what patients tend to do well regarding responding to each possible treatment option? Is there some overarching kind of commonality that we can think of? And I hate to say a generalization, but what type of patients, are there any profiles or types of patients that tend to respond well to some of these treatment options?
Great question, but a little bit challenging to answer in that I think we just need a little bit more data over time to answer that a little better in terms of, is there specific race, is there specific age, is there specific like GFR, is there specific proteinuria? I will say, to be honest, I think the goal is, I think now to act quickly and have this duality in approach. So not do one first. So prior, I would say a few years ago, our approach was just do RAS and SGL2 or RAS itself and wait, right? Now it's like, should we do RAS and then maybe a little bit of budesonide or a little bit of steroids up front? And then if the RAS is not enough, then you can add SGL2, which was not an option before. Meaning like if it's not causing the protein to, so, it's hard, I would say at this point to say, because you come like this, I'm going to give you sparsentan first, and I'm not going to give you ACE. I think the way to look at it is that ACE is easily, like RAS inhibition is easily accessible. It's safe, it's cheap. There's a lot of data around it, easily available through, no concerns with insurance approval. So start them on RAS inhibition, increase and up titrate the dose, see how your patient's tolerating it. And if that's not leading to the desired effect in about a couple of weeks to months, then you have other options like sparsentan that you can start considering that you can add on, or SGL2 that you can add on to achieve that, the effect in terms of reducing protein. But I don't think there's a specific patient profile that I would think of. In the other group of patients, if for some reason steroids are just not the right drugs for you or high dose is not the right drug for you because of, other risk factors that you already have, then certain things like the complement inhibitor could be a better one, or the budesonide, which is less toxic, could be another one.
I think another question too. Thank you for that. Also, I want to make sure people know that this recording will be available on our YouTube. Also, we can make these slides available too, to everyone registered. So I can for sure ensure that you all get them. But another question I had, that's been posed to me is, what advice do you have to help patients make an informed decision about the best treatment option for them? Which I know is difficult as well. But what's some general advice you can give a patient regarding making an informed decision when it comes to possible treatment options?
I think the general advice would be, I think, really sitting down with your nephrologist and your treatment provider to understand all aspects of your disease, meaning
Mm,
level of protein over time, right? What is the average amount of protein that you've had in terms of the range? Asking the question of exactly what the biopsy shows. There's how much damage is already there, how much of it looks acute or chronic, asking where the kidney function settles or is at that point based on your age and how old you are, and looking at that risk tool that we all have access to and seeing if you plug all of this in and in addition put your race and blood pressure data in it, what does that tell you in terms of your risk for progression of disease, right? And based on that, discuss, do you think the medicines I'm on right now are enough? And then what is the plan to monitor this? Like, how often should I see these things improve? And if they don't improve, then what is the next step? Kind of that's sort of what I would counsel patients about. All medications will have some side effects or the other. Typically, the CKD, like the RAS inhibition, the sparsentan, they don't have long-term side effects, but they can make you feel a little lightheaded or dizzy, or they can make your electrolytes a little wonky, or and everybody responds differently. So I think it also will end up being a little bit of what your body can take in terms of medications, right? So I think that's also important discussion to have to do with your provider, and go from there. So I think that is the most informed decision there is. Obviously, the clinical glove, there are all these data on the current clinical trials that are ongoing for IgA nephropathy that I would also encourage patients to ask their center or nephrologist whether their center participates in any trials, or if there's a close by center that has some active clinical trials going on that they could potentially, participate in, because a lot of the IgA trials are still ongoing, and not every center probably has every trial, going on. So those could be the things I would have patients ask.
Thank you. And I also want to piggyback off of that and say that from NephCure standpoint, our clinical trial tool is being extremely fine-tuned by our own Britta Dornan's department, as well as partnership with others. And we should have that up and running. I don't want Britta to shoot me, but we should have that up and functioning really well. Her team is working hard on it, hopefully by the end of the month or maybe next month. And so check back at nephcure.org. I look forward to having an announcement out about that, or NephCure does in general, so that we can announce that tool being fully functional and working. If any of you attended the April 1 town hall a few weeks ago, our manager of physician relationships, Kelsey, actually presented on our clinical trial tool. So we have one on our website. Please look at nephcure.org. Please keep checking back. If you have any questions, you can reach out to myself, Susan, or anyone else at NephCure, and we'll be able to update you. I did have another question, Dr. I know you're presenting, but this is what happens. Everyone gets
I
excited.
love this. I think this is what makes it more interesting than
Yeah.
me just thinking. So I totally appreciate this.
Oh, you're welcome. You're welcome, and thank you. So we had another question. You spoke about the 18-year-old who arrived with kidney failure and hadn't had a urine test in years, despite prior health issues. Given the absence of universal screening regulations in the U.S., what changes, whether clinical, systematic, or policy-driven, do you think could realistically help us catch pediatric IgAN earlier, especially in high-risk populations? Go ahead, Rihanna.
Great question. I really think it's the urine analysis is probably the most the easiest screening tool in terms of its easy access and pretty good sensitivity. And I really truly wondered with this Asian patient. I will be honest, IgA nephropathy leading to kidney failure in the pediatric world is not very common. We see kidney failure from many other GN diseases, but IgA tends to not be, can cause like kidney disease, can cause protein hypertension, but like really developing kidney failure is rare. And so this really struck with me because especially in the Asian population, I really wonder, even though the practice here in the United States is not to do screening UAs for our pediatric patients, I wonder for Asian patients if that's just something we should do. There are certain pediatric offices who just do once a year urine test at your annual well check visit. And sometimes we as nephrologists get very annoyed because we get all false positive referrals. It's like, it's not true protein, it's not true blood in the urine. Why are you checking? Why are you sending? But I guess when you see these cases, I would wonder. I think that's the biggest thing is screening UAs. I don't think anything else in symptoms or blood tests I can think of. Because I think in her case, if she ever had visible blood, she would be seen because she's like, oh, why is my urine looking red? It's just that she probably had what we say microscopic or hidden blood and maybe very low or mild or moderate levels of protein that didn't show up as symptoms. And IgA can cause a pattern like FSGS, on your kidney biopsy that can progress over time. So it's just unfortunate.
Thank you so much, Dr. Daga. Also, I want to note that though, because of licensing, clinical license issues and scope, Dr. Daga may not be able to answer specified questions about your labs and your current state, but you can follow up with us. I put my email in the chat and you can email me, and I can connect you with someone who can give you the correct answers about your personal clinical state. Just with scope and license, Daga cannot give worldwide clinical advice based on specified clinicals from specified patients. However, I will say that the patient did have a question. Oh, thanks, Britta. We do encourage all patients, this is from Britta Jordan. We encourage all patients and caregivers to explore NephCure's clinical trial matching tool. You will see improvements to the site early this summer, and that will make it even more user-friendly. Remember, clinical trials are a form of treatment. Talk to your provider to see if a clinical trial is right for you. Thank you, Britta. I like that. Thank you so much. So do you want to continue, Dr. Daga?
Yeah, I'm almost done. I just want to kind of, I think I don't, I just had some little bit more granular data on the trials, but I think that uh, essentially just saying that we have many more, some approved medications now to use and some that we have clinical trials. So like steroids and the budesonide for sure. And these are just the classes of medications that, I described and just the mechanism of how they're working. And just to thank everyone for letting me, be here and join this community. And it's really humbling always to, care for patients and really try to save every nephron or kidney cell one day at a time. But what I would say is that in my career, which is not for very many years right now, there's been a big shift in understanding IgA nephropathy and trying to really serve the patients and the community and kind of really treat them and give them like all these medications that I talked about, like budesonide didn't exist a few years ago in terms of an option that was available, or iptacopan or other things. So there's definitely options. I think what we are going to learn in the next few years is the newer drugs that come, but also like which one would be best for which patient and kind of how do we maximize the benefit and minimize the risk in an ideal world and eventually save them from developing kidney failure. Thank you all.
No, thank you. So we can take a few more questions for Dr. Jagger, like I said before. If you have any questions in regards to your personal labs or what's going on with you as far as specified clinicals, we can help you, but we just need you to reach out to us so we can find somebody that can help you that's local to you and has jurisdiction in a clinical way to help you. But if you have any general questions at all, please put them in the chat at this time so that we can get possible some answers. So, what are your thoughts about you're gonna be do you have any thoughts that you feel comfortable sharing about that?
Um, you know, it's a very open-ended question. I I think I will be honest, it's also now recently, Fabhalta has been approved for a different GN condition recently. Um, and it's definitely the data is compelling for both that condition and IgA. We have to wait and see what the 2-year data pans out because what we have so far is a 9-month data, and it is encouraging to see reduction of protein and improvement and safety profile because this is a complement blockade, right? So it increases anyone who takes a medicine like iptacopan or Fableta is at risk of developing bacterial infections like meningococcal and pneumococcal because you're suppressing your own immune system's ability to fight these infections that can make you really sick. So you really have to be immunized against these, and you have to be aware of this risk if you take this medication. In the trial, nobody had these side effects or these adverse effects happen, but I would be curious to see what that pans out with time, right? So I mean, the data is compelling, but I think I want more. But it is an option for patients who have steroid toxicity or, other things.
Thank you so much. I had another patient who had an interesting comment. With doctors not doing urine tests yearly, my doctor confessed that he had little training about the kidneys. He did a urine test only because I demanded. Yeah, that's definitely a problem, Barbara. Anybody's on the call who has who feel like they're in this situation, if you've not gotten a urine screening and you are interested in getting one, which of course, me even not being clinical, I would recommend. We can help you and give you assistance with that. We for sure can. So if you need assistance with your analysis, if you need assistance with any testing that you feel like you need to be getting, please reach out to NephCure and we can for sure link you with someone who can help you. I did get another question about FSGS, which, interesting enough, shameless plug, we'll be having the FSGS Awareness Town Hall on June 10th, where we'll have two amazing specialists talk about the new possible treatment options on the horizon, as well as a patient who will share their experience as well. So we'll have Dr. Ristogi from UCLA and Dr. Campbell, who just moved to Philly, who's actually on our board of directors, who they will be presenting as two leading experts, and they will dive deep into FSGS. It'll be on June 10th. So please look on our site, register as soon as possible. Thanks, Khadija. Register as soon as possible. And if you register for the FSGS Awareness Town Hall, we will make sure we'll make information given to you. It should be on the calendar within this week on our website, Khadija, on our current, like same when you register for this one, you can register for the FSGS Awareness Town Hall, and I'll share that at the end as well. Okay, I'll put it in for you. It's nephcure.org. So if you go there, you should see the upcoming events and you can register for it. Have you seen any familial cases of IgAN in Asian populations?
I have, and I think that we don't still quite understand why that happens. There are certain studies that are looking at genome-wide studies that are looking at certain polymorphism in your genetic makeup that may act as a risk factor for making those extra autoantibodies. Having said that, if you do have a family member with IgA, I think it's reasonable to check your urine and get screened. And we've seen patients like that in my clinic as well. And then there was another question of, what's the one thing you wish more people understood about living with IgA as a young person? I think the biggest thing I struggle with is if you just have primary IgA nephropathy with little blood or protein in the urine, you feel well. You don't have any symptoms many times. And I think often I struggle with adherence to medications or telling young teenagers to like keep taking the meds. Some of them, I know it's hard and life happens, but one thing would be that it's the rate of loss of kidney cells can be accelerated in patients with IgA nephropathy. So be a good friend with your doctor, find your good nephrologist, and just try your best to take these medications.
Thank you so much. So in answering that, we had another person who asked, is IgAN hereditary? Thank you, Barbara, for that question.
No, we don't have enough information to say that. Why it's more common in Asian people. We have seen patients have it. One person in the family has it, no one else has it. We've seen 1 or 2 patients in one family have it. But it's not that where we've not identified a single genetic cause so that we can say it's hereditary.
Thank you so much for that as well. So Dr. Daga, thank you so much. That was incredible. I will make all this available to everyone who registered. That you did incredible. That was your first time, and it won't be your last. Don't worry. I'll be asking you so many more times to come on back, either in person and virtually. You're now stuck with us, so God bless you. But it'll be great. Um,
Thank you.
so now moving into, I think the most important way to illustrate how important spreading awareness is by asking patients themselves and patient families. So we have an adult patient that is phoned in, Judy Aiken, who's IgAN patient, who's incredible. Judy, I'll be making you don't have to share yourself on the screen, Judy, but I will be adding you as a panelist so that you can speak and ensure that you give your story as well. So we have Becca and Bria Garcia from New Mexico. Becca's a teen with IgAN, and Bria's a teen with IgAN, and Becca is her mother. So just to start out, asking you all the first questions, Bria, I'm going to ask you first and foremost, based about your experience. Before you were diagnosed with IgAN, how did you feel? How could you tell something was off?
Um, well, I started with HSP, so I noticed the rash on my legs and like my lower back, and obviously that's not normal for like a 9-year-old to have. So I went to my mom, and then I got diagnosed.
And then how has that changed your day-to-day life since being diagnosed with IgAN?
Um, it's changed like how I learn in school, and like it's changed my sports. Like I don't do sports anymore, and it's kind of like changed my durability and energy throughout the day. Yeah.
Thank you. And Becca, in piggybacking off of that, how has Bria's diagnosis changed your family's dynamic as well as your day-to-day?
Um, it changed it quite significantly, we had to change her diet, which was really hard for a kid, just wanting to be a kid.
Sure.
When she talks about the energy, that was really hard too because as you can see, she's a beautiful girl. She looks really healthy. You would not know that my daughter's on dialysis right now. So she does have end-stage renal disease because of IgA nephropathy and HSP. So before dialysis though, she didn't it's hard. Your kidneys aren't working, you're not feeling good, you don't have the energy to do things, but yet she wanted to, like she wanted to go do things with her friends or go play recess with the kids in her grade, but there was quite times she was just hanging out with like the teachers in the room because she didn't feel good. Or she was just trying to get through the day.
Yeah, that makes sense. And did you mention what type of dialysis? What mode?
No, she's currently on PD dialysis, which we love. If anyone's ever like thinking PD or hemo, I was really, as her mom, I was like, there's no way I could do this. There's no way I'm gonna be able to do this in my home. But guess what? If you if you scooch a little bit, you can see all our Baxter boxes right there. Yes, we don't use our dining room anymore because it's our storage area. But we do PD and it's phenomenal. She can do it while she sleeps. We don't have to go into a hospital. We've had no complications. We do treat it like a sterile procedure every evening. So I would just say in the beginning, I was afraid of PD. But we've been doing it for a year now, and if anyone's ever wanting just to have some normalcy to their life, PD is super helpful.
So even doing PD, has that changed you all's day-to-day lives? How's that impacted you all's traveling? And I know you spoke about possibly like an event in the summer that you want her to attend, but you can't. How's that kind of augmented that?
Well, we've gotten really good at it. In the beginning, we had our little bag that they give you for your machine, and we carried that thing with us. We just attended NephCure's Patient Summit in New York, And I got smart and I was like, you know what? We are not carrying that bag all the way through the airport. So I found a luggage that it fit in. And guess what? I wheeled that machine with us, and it's super nice because like the company will ship the fluid and everything. We're just responsible for taking the machine, all the connecting parts and the cleaning parts. So really it was easy to travel. Um, it does take some planning, and it's a little nerve-wracking because sometimes you're like, okay, hey, did the solution show up to the hotel?
Right.
But those are things that you just gotta work through and you know, advocate for your kids. Like, don't take no for an answer. Like, be like, hey, I need somebody to go check. I remember Montrez, you were super helpful when we got to New York. They were saying that like our supplies was not there and we were scheduled to leave the next day and nobody could find her solution. And we were like kind of panicking, like, what are
Right.
we gonna do? Because we need that. Like we need that every single night. So sometimes it is difficult, but there's plenty of options for her to have a normal life. And they can be difficult at times, but we just work through them and staying strong and just taking it one day at a time.
I think that should be we should have a t-shirt that says that. I swear, everyone. So flexing to you, Judy. Thank you so much. I put you on the spot here. She's my girl. I've known Judy since I started here at NephCure, and she's been so helpful as far as helping not only myself understand, but everyone else understand the patient journey, but also in particular the IgAN patient journey, which has been very helpful. So as an adult patient, Judy, when were you diagnosed, and what has your treatment journey looked like since your diagnosis? You're on mute, dear.
Sorry about that. I was diagnosed in 2019, and I was put on prednisone right away. I was actually in the hospital for a few days on like very high doses of steroids while they were trying to determine what I had. Since then, I went plant-based not too long after I got diagnosed, and with that and the prednisone and the losartan for the blood pressure and fish oil, I was actually able to get myself stable. And in a baseline of 40 to 45, I was diagnosed at 22%. So I was able to get those numbers back up just by, huge lifestyle changes and taking the meds as prescribed. In 2021, I was taken off prednisone and was only taking fish oil and losartan. I'm still only taking fish oil and losartan. I did briefly go into a remission, but we are thinking that it's active again. So we will see. I just moved to Nevada. So I have my first appointment with a kidney IgA nephropathy specialist actually here in Vegas in a week from today. So hopefully, we'll figure out what we're going to do and see exactly where my kidneys are at.
Yeah. And I know we talked about this before. I think we kind of did this before. It's like almost like deja vu. But we have a lot of new patients since our first time doing this. How has this affected? You're still pretty young too, Judy. How has this affected your day-to-day life as far as being a mom, as well as being someone still within the career world?
So because the career that I did was very hands-on and a lot of hours and very high stress, I actually stopped working in my career. Just because it was too much for me physically and mentally. As far as being a mom, it's probably the thing that's been the hardest for me. From being on prednisone and having prednisone affect me the way that it did and how that affected my child, to just living every single day with that little voice in the back of your head that says, hey, you may not get to see him graduate from high school. You may not get to see him get married. You may never meet your grandchildren if he has grandchildren. It's something that's really hard to live with. I have gotten to a point where, he's older now, So we have a lot of conversations and we do a lot of fun stuff together just to make sure that we are getting those memories in and making sure, you know, we're spending as much time together as we can.
That makes complete sense. Back to you, Bria. I'm sure you probably know a lot more about your health than, say, your peers do as teenagers. How does that affect your relationships with your peers?
I mean, it doesn't affect my relationships with my peers so much. Like, it's hard to explain it to them because, like, they're like kind of insensitive. They just don't know, like, not in a bad way. It's hard to explain to them because not a lot of people know about what the kidneys do and like how they function and help your body. So, like, if like the people I choose to tell, like, it's hard to explain to them because like I have to bring it down a few levels so someone can understand.
Yeah. What's a question that you wish, and I'll ask you the same question, Judy. What's the question you wish that your doctor would have asked you in the beginning when you were diagnosed?
I don't know. I'm not sure.
What about you, Becca?
Something that they would have asked me.
Mm-hmm.
I don't think there's something I wish they would have asked me, but I wish they wouldn't have said, hey, this is okay. She can live with this her whole life. Like, nobody ever said after being diagnosed with IgAN that we would possibly be on dialysis. Her disease, she was diagnosed in 2020. So really, it's only been 5 years. So that's a lot for a child to go through. And I wish that the doctors would have not sugarcoated it and been like, hey, like this is going to be good. She's going to be on prednisone. It'll take care of her. I kind of wish that like there was more knowledge on IgAN patients and the disease itself. And I think we're getting there with town halls like this and Dr. Daga, like people just advocating for this disease and getting more nephrologists out there that are hungry to learn and find a cure for the future.
Thank
I
you.
know there's Rhiannon asked Bria a question here. What would you tell other teens going through something similar?
I would probably just give them my perspective on like my personal journey and like what I've gone through and like just like how to like cope with things, how to make it easier.
Sure. Judy, what about you? What do you wish that would have been asked of you, or how Becca reframed it in an amazing way? What do you think is something that should have been told to you when you were first diagnosed?
I think as far as being asked, it would have been nice to be asked what I was thinking in that moment. I was fortunate with a really great nephrologist, but that first diagnosis moment, we didn't really know each other yet.
Mm-hmm.
So it would have been nice for him just to kind of see where I was at in that moment and not just start throwing papers at me about what everything is.
Yes. I think at NephCure too, I think one thing that we've done a good job about is pacing the information that comes out because people, you've taught me that, Judy, so many other families have taught me that as well. Too much information at once is overwhelming and it's extremely scary.
Yeah. I went home with a stack of papers like this. And it was nutrition, it was everything. And when you get a diagnosis like that, you got to process before you can really start listening to what they're saying. So
Mhm.
I think really what would have been nice is for him to do a brief description, just a brief, like, this is what you have. Ask me how I'm doing with it, kind of give a brief description of it, ask me how I'm doing with it, and then give me some time to process before you start throwing a bunch of papers at me.
Yeah,
Yeah.
agreed. Agreed so much. Thank you so much for saying that. I think our major takeaways from hearing both of you all, both Bria, which thank you, Bria, for doing this for me, and Becca, as well as you, Judy, is advocating for self and also as far as information thrown at you, you want doctors to know that they have to pace themselves when it comes to that so that you don't become overwhelmed. And also
Mhm.
that this disease does indeed have great deal of emotional and mental impact on your lives that people need to be sensitive to and be aware of.
Mhm.
Can you all both give me one thing you tell a newly diagnosed patient? Judy?
Um, always advocate for yourself. Always, always remember that when it comes to your medical care, you're the boss. You're
Mm,
in charge, and you get to make the decisions that are going to be best for you and your life and your family. And the doctor should be there to support that.
thank you. Thank you, Judy. And Becca, Bria, what's one thing you tell a newly diagnosed patient? What line of advice would you give them? No pressure.
Um, I would probably say um, like just like to be resilient and stay strong, keep an open mindset.
That's powerful. Thank you so much for that. Thank you, Becca. Thank you, Bria. Thank you, Judy. So now I have the great honor of introducing our next presenter, Miss Susan. I almost said doctor. Miss Susan, not quite. This is Susan Brizendine, who is our VP of Partnerships and Collaborations at NephCure, and also who has taken the great task of building out NephCure's first IgAN Alliance, and the only one I've honestly ever heard of. So we're so excited to have Susan. Susan's going to now give you all a bit of information, present to you all about what this IgAN Alliance is and how it can be of support to you all.
Yeah.
So you can share, Susan.
Okay, I'm going to share a few slides. I know we're at time, just a couple minutes, and I'm going to probably talk pretty fast and quickly, but as Mantra said, these slides will be made available to you. So let's see. Can you see my screen?
It's coming.
Okay.
There we go.
Okay. All right, good. So,
Mhm.
yes, it's a pleasure to be here, and thanks again to the presenters. Really enjoyed all the information you shared, and thank you for being, having the courage to share some of your experiences. I'm just here to talk very briefly about a new program we are rolling out this year and next around the IgAN Alliance. It's called the IgAN Alliance, and so I just want to give you a quick update on that. I don't need to tell you any longer, the challenges with IgAN diagnosis and treatment. We hear it all the time, right? It takes a long time to get diagnosed and sometimes a while to get access to treatment options or to understand the treatment options that are available to you. And that is really important. It's, as Dr. Daga said, this was considered a benign condition for a long time, but the outcomes are not benign, right? It's important that we creates more urgency around diagnosis, around treatment, make the patient journey or journey so much easier for all of you. And that's what we're here to help you do at NephCure. So we're trying to address this problem with the IgAN Alliance. And what is the IgAN Alliance? Very briefly, it's really a first of its kind collaborative effort among all the stakeholders involved in diagnosing and treating IgAN to try and create more urgency around that accurate diagnosis and helping you make informed decisions about the newer treatment options that are available or what treatment options might be right for you. I mean, for example, Judith, has made lifestyle changes. There's different approaches for different patients, but there are new and exciting innovations out there, and we want to help you have a productive conversation with your doctors to understand what might be right for you and help you make those decisions. But there are some barriers to diagnosis and treatment. So the goals of this program, very briefly, we have 5. One is to kind of understand what those barriers are to improved care and treatment for IgAN patients. How do we, Becca talked about the importance of more awareness and more education out there, right, about IgAN among all of these stakeholders, insurance companies and doctors and patients and policymakers and all the different audiences that are involved in care and treatment of these IgAN patients. We need to help them understand the importance and the urgency of diagnosis and treatment. We want to empower you, right? We want you to be that empowered patient to pursue optimal care. Judith was talking about you're in charge, right? You have a lot of control in demanding, optimal care and treatment. So how can we help you do that? And then again, underscoring the importance of early diagnosis and treatment, given, that outcomes are better in patients who are diagnosed and treated earlier, right? Outcomes are better. Patients do better. So how can we get them there faster? And of course, just engage all of these people in the solution. So a few ways you can get involved. First of all, you can go to our IgAN website, which is listed here, and you can download our IgAN handbook. A really great resource for anybody dealing in this space in their health. We are going to be sending out a patient survey in the coming weeks. And so please watch for that. If you've registered for this webinar, you're on that email list. If you're not, please contact us so that we can keep you informed about some of these updates around this program. But we want to understand, what has your experience been like? What has your journey been like? We want to understand the barriers and how to address them. We want you to engage with us on social, right? On Instagram and on Facebook. We want you to share our content with others who could benefit from it. And again, let us know if you want to keep updated about what's coming out with this program. What next is we're also going to talk to doctors. We're going to hear from them about what some of the barriers are. We're hosting a workshop with some of these stakeholders to understand the barriers and come up with solutions. We're issuing more content so you can watch for more educational materials, including an updated handbook. And then we're expanding some of the services that Montrez and his team provide just around patient support, patient navigation, helping you get the care that you really deserve. So that is the IgAN Alliance, and we look so forward to involving you in the process and helping you find solutions so you can get better care and treatment. So we're working hard on your behalf, and I want you to know that. So thanks for the time, Montrez. I know that went a little long.
Susan, you're a racehorse. I'm scared of you.
Did you understand me speaking so fast?
You've been a great professor in school, because it would have been great to have your class.
Speed talking. Well, there'll be a quiz.
Got us through it.
From Dr. Brazil.
Dr. Mandam, hello. So nice to have you. Dr. Mandam just came on and said, please participate in clinical trials. That is the only way we can get new medicines to cure IgAN. So true. Thank you so much, Dr. Mandam, for saying that. And also, thank you, Susan. That was great. That was amazing. To echo Susan, you will for sure get these presentations in your email. I'll make sure they go to you probably by the end of this week, both sets, as well as this whole recording will be available on our YouTube, as well as our website, as our NephCure.org website. Please, please, please. Kylie and the marketing team has done a great job, and Hillary and everyone involved has done a great job revamping our NephCure website. It is so much user-friendly than it was. It's amazing. So please look through it. You will see resources for IgAN. You will see so much information on IgAN, including this town hall. And also feel free to reach out to us. We quickly respond. If you need any assistance, please reach out to us. Next, I want to thank Becca Garcia and Bria Garcia for being brave enough to share their story and their experience. as well as Judy Aiken for always leaning in and helping other patients who are new and helping them get activated as you so gracefully done, Judy. And also Dr. Jaga, our new close friend now, who we're going to call on, and plug into our NephCure family. And of course to Susan, who's an amazing addition to the NephCure family and has already made big waves. So thank you all. If you need anything, please reach out to NephCure. We're here for you. We support you. And happy second annual IgAN Awareness Day from NephCure. All right,
Thanks,
y'all.
everyone.
Have a good
Good
night.
night.